Hello, everyone. My name is Dr. Michael Albright. I'm an internal medicine primary care physician, and today I'll be giving an overview of GERD, or gastroesophageal reflux disease. Just as a disclaimer, the material presented here is for informational purposes only. It is not intended to diagnose or treat disease. Speak to your personal healthcare professional for any medical advice. I'll be giving a broad overview of GERD in this talk, including what is GERD, what causes GERD, what are the symptoms, what can GERD do if left unchecked, what can my primary care doctor or specialist do for GERD, when should surgery be considered, and more. So what is GERD? GERD is gastroesophageal reflux disease. Gastro is a medical term meaning stomach. Esophageal means esophagus. Reflux means fluid backing up. And disease is a disorder causing a problem in the body. So if you put all these together, GERD is a common disease where stomach acid repeatedly flows back up into the tube connecting the mouth and the stomach called the esophagus. When acid refluxes into the esophagus, it can damage both the lining of the esophagus and possibly the throat. GERD is present when this reflux causes symptoms or complications. What causes GERD? Well, reflux happens a little bit in everybody, but when there's too much acid reflux, it can cause problems and damage the lining of the esophagus and other structures, even all the way up into the throat. There is a tight muscle where the esophagus meets the stomach, known as the LES, and I'll show that in the image to the right. You can see that the orange tube coming down from the throat is the esophagus, and this meets the stomach at the bottom. The LES is between the esophagus and the stomach. The LES is also known as the lower esophageal sphincter. It's a circular muscle that lets food into the stomach when we swallow and is designed to prevent acid from refluxing back into the esophagus. Different things make it so that this LES muscle isn't as tight, and this can let in more acid than usual into the esophagus. I like to think of the lower esophageal sphincter sort of like a camera lens in terms of how it opens and closes. So it's not exactly like this, but if you think about a lens that closes in kind of a circular fashion as depicted in the picture here, you can kind of understand how the LES opens and closes. It normally lets food into the stomach when it opens, and then it immediately closes again to prevent reflux. There are certain things that increase the chances of getting GERD. One of those is increased abdominal pressure. Obesity and pregnancy are examples of conditions that increase abdominal pressure and increase the risk of developing GERD. There are certain substances that make the lower esophageal sphincter relax and let in more acid, such as chocolate, carbonated beverages, alcohol, caffeine, certain medications. Everybody's different in terms of what might trigger their GERD. Increased stomach acid production can be a cause of increased GERD. There's a rare condition known as Zollinger-Ellison syndrome, where there's too much acid production in the stomach. Slower contractions of the stomach or esophagus can also cause GERD, such as gastroparesis, which is a slow stomach seen in diabetes. There are also anatomical changes such as hiatal hernia that we'll talk about later that can also contribute to GERD. As you can see in the image on the right, we see the stomach, we see the esophagus, and then there is this muscle kind of in between the two of them on the sides, known as the diaphragm. The diaphragm is a flat muscle between our lungs and our abdominal cavity that contracts to pull the lungs open when we take a breath. There is a hole in the middle of the diaphragm where the esophagus travels through to connect with the stomach. A hiatal hernia is where the stomach is pulled up through the diaphragm muscle into the chest. The lower esophageal sphincter has a harder time keeping acid from refluxing when the stomach is pulled up into the chest in this fashion. GERD consists of typical and atypical symptoms. Typical symptoms are present about 70% of the time in patients with GERD. The first symptom is heartburn, which is a burning sensation in the chest. The second typical symptom is regurgitation. This is the sensation of stomach contents coming back up into the throat. Atypical symptoms of GERD are numerous and can include discomfort in the upper part of the abdomen or what's called non-cardiac chest pain, nausea or belching, trouble swallowing or pain with swallowing, throat clearing, sore throat or sensation of something lodged in the throat, chronic cough, wheezing, or even tooth erosions. What other conditions mimic GERD? Well, the first is heart disease. Heart disease can be an impending heart attack or even other heart conditions. And this is probably the condition your doctor will worry about the most as something to rule out prior to considering a formal diagnosis of GERD. Other stomach problems such as stomach ulcers, stomach inflammation, or gallbladder disease can mimic GERD. Other esophagus problems such as inflammation of the esophagus from pills or other causes, esophageal cancer, and esophageal movement disorders, also known as esophageal motility disorders like achalasia. And then chest wall pain is also common. Muscles or cartilage of the rib cage can become inflamed for various reasons and mimic GERD. What can GERD do if left unchecked? Well, erosions can occur in the esophagus from all the acid and pepsin that comes out of the stomach into the esophagus. And this can range from mild to severe. Doctors call this condition esophagitis. Ulcers can even occur in the esophagus. Barrett esophagus can occur. This is a precancerous change in the esophagus that generally needs a biopsy to be seen under the microscope for confirmation. Cancer of the esophagus, also known as esophageal adenocarcinoma, can occur in the setting of GERD over time. And strictures in the esophagus. So a stricture is a narrowing. And as you can see in the image of the X-ray on the right, the esophageal stricture is in that yellow circle. You can see that the barium that is swallowed by the patient in this X-ray is suddenly narrowed when it gets to a certain part in the esophagus, and that's due to a stricture. So what can a primary care doctor do for GERD? Your doctor may recommend medications to you. They may prescribe a medication class known as proton pump inhibitors or PPIs to you. A PPI trial may be given once daily for 8 weeks to see if it improves GERD symptoms before doing any other testing. Lifestyle changes may be recommended to you as well. In fact, they should be recommended to you if you have GERD, as this can help you avoid GERD symptoms even without taking medications in some cases. So avoiding large meals is essential to help prevent GERD, as it increases abdominal pressure whenever you eat a large meal and you pack your stomach too full of food. And also avoiding trigger foods that you know will trigger the GERD. So for some people, this is alcohol. Some people, it's caffeine, coffee, chocolate, pizza, other things, spicy foods may trigger it for you. Nocturnal symptoms can sometimes be helped by elevating the head of your bed at night, avoiding meals 2 to 3 hours prior to bedtime, and then anatomically sleeping on your left side can be beneficial for reducing the amount of reflux that is happening at night. Some people also take a medication at night known as an H2 blocker, or Pepsid is an example of that can help reduce nighttime symptoms. Losing weight, if overweight, can decrease GERD symptoms by 40% or more, so strongly consider trying to lose weight if you are very overweight. Quitting smoking is important, as smoking inflames the esophagus. Alcohol can also inflame the esophagus. Marijuana can inflame the esophagus. So consider reducing these in order to improve GERD symptoms. And then referring to a specialist such as a GI specialist. We talked about PPIs briefly on the previous slide, but PPIs are proton pump inhibitors. It's a class of medications. They are the most powerful medications available to reduce the stomach's ability to make acid. The generic name of these drugs always ends in prazole, so we can always recognize when a medication is a PPI if it ends in prazole. Examples of that are omeprazole or Prilosec, esomeprazole or Nexium, lansoprazole or Prevacid, pantoprazole or Protonix, dexlansoprazole or Dexilant, and rabeprazole or Acifex. When a primary care physician or provider refers to a specialist, they're usually expecting the specialist is going to perform what is known as an upper endoscopy. An upper endoscopy is sort of like the opposite of a colonoscopy, which is a lower endoscopy. An upper endoscopy is also known as an EGD, which stands for a very long medical word called esophagogastroduodenoscopy. On the right is the instrument that is used in an EGD or upper endoscopy, and this is known as an endoscope. You can see there's a light at the very end of the tube there, and there's also a camera on the end of the tube that allows the physician to view what is going on in the esophagus and stomach on a television screen. And this is depicted in the bottom right image. You can see that the doctor is holding the end of the endoscope tube in his hand, in the right hand, and feeding it through the patient's mouth, who's lying on his or her left side. And there is a white mouth guard in the patient's mouth that the physician is feeding the endoscope through. You can see that the physician is actually looking at a television screen to visualize what is going on during the procedure. The patient is sedated, so lightly sedated during the procedure. Typical GERD symptoms that persist after a PPI trial are one reason to perform an upper endoscopy. Another reason is for alarm symptoms. These are symptoms that could suggest something more serious is going on, such as a stricture or even esophageal cancer. So trouble swallowing or painful swallowing, bleeding or iron deficiency, not feeling like eating, what we call anorexia, weight loss, and unexplained vomiting can be alarm symptoms that suggest we need to go straight to an EGD. Atypical GERD symptoms can be a reason for upper endoscopy. Confirming lack of healing of Barrett esophagus in patients with a history of erosions of the esophagus or erosive esophagitis can be a reason for an EGD. Treating an esophageal stricture can be a reason for an upper endoscopy. So an esophageal stricture, remember, is a narrowing of the esophagus that can be caused or contributed to by GERD over time. And patients sometimes who have these will have to get periodic balloon dilations of their stricture. So the GI specialist will go down with the endoscope, use a balloon to push open the edges of the stricture so that the patient can swallow easier. Another reason for an upper endoscopy is screening for Barrett's esophagus in men older than 50 years with long-standing GERD and additional risk factors. Surveillance of known Barrett esophagus to make sure that esophageal cancer isn't developing is another reason. This procedure may be performed prior to anti-reflux surgery. Your specialist may recommend other tests, especially if the diagnosis of GERD is in question and they're wondering if something else might be going on, such as an esophageal motility disorder. So esophageal manometry is one test. This is a test to evaluate the esophagus's movement during swallowing and also the pressure while swallowing. You can see in the image on the right that both of these tests use a tube that goes through the nose and is fed into the esophagus and stomach to detect different things. So manometry is used to detect pressure changes in the esophagus, and the pH testing is done to see if there are pH changes to suggest increased acid in the esophagus. So esophageal manometry, like I said, is used to tell if a patient has problems with the esophagus moving or a movement disorder. We call them motility disorders that prevent patients from swallowing properly. And these symptoms of these motility disorders can sometimes mimic GERD. A tube is inserted into the nose, down into the back of the throat, and into the esophagus and stomach. The tube has numerous cylindrical pressure sensors along its length, and I will put a link in the description for another video on YouTube which shows this procedure in more detail. During the procedure, the patient is asked to do different swallowing tests while the tube is in place. For esophageal pH testing, this is used to tell if a patient is having reflux, how long, and how high up the reflux reaches. The tube is generally in place for 24 hours. The manometry test is usually done within, the same day, whereas the pH testing you have to take home with a tube in your nose for 24 hours. So what are some over-the-counter medications that can be used to treat GERD symptoms? I already mentioned the PPI medications, but some others that are used for more mild GERD symptoms are antacids. Antacids work by neutralizing stomach acid. So if you remember from probably grade school or middle school or high school, a base will neutralize an acid. And that's what an antacid is. It's a base compound. And these work quickly, but they don't last very long. They last up to 1 to 2 hours. Some examples are calcium carbonate or Tums, or aluminum magnesium hydroxide, brand names of Mylanta and Malox, and there are many others. H2 blockers or histamine 2 receptor blockers block stomach acid for up to 12 hours, but they're less powerful than PPIs. A lot of patients use these medications as needed to treat GERD symptoms. A lot of people use them at night, and you can use them in addition to PPIs or antacids. You'll know that a medication is an H2 blocker if it ends in tidine. For example, famotidine or Pepcid, nizatidine or Axid, and cimetidine or Tagamet. There used to be another one on the market that was removed because it had a potential cancer-causing substance in it, known as ranitidine. The brand name was Zantac, but it's no longer on the market. So how do we know which medication type to use? Well, the PPIs are probably going to be recommended by your doctor as they're the most powerful medications, and we often use them in that 8-week PPI trial to see if this improves GERD symptoms. PPIs can be used for long-term maintenance if GERD can't be controlled without medication, Or if there are more serious things going on in the esophagus, we're probably going to recommend PPIs over other things. So if you have erosive esophagitis or esophagus erosions, stricture or Barrett esophagus, we're probably going to recommend PPIs. If symptoms improve and there's no erosion, stricture, or Barrett's esophagus, we're probably going to recommend that you taper off or stop these medications over time. H2 blockers and antacids we talked a little bit about, but these are used as needed over the counter if GERD symptoms are mild and if they work. If neither of these work, or if the diagnosis of GERD is clear, we'll try switching to a different medication or adding proton pump inhibitor medication. Some patients take the H2 blockers every night with or without also taking a proton pump inhibitor. However, your body can get used to H2 blockers over time, so they may become ineffective if you take them long-term every night. I just wanted to briefly mention that I came across a new medication as I was doing the research for this talk. It was called vonoprazan. It is a potassium competitive acid blocker, or PCAB. It seems to work similarly to proton pump inhibitors by reducing acid production in the stomach. And it was approved by the FDA in November of 2023 to treat erosions in the esophagus, also known as erosive esophagitis. It can also be used in combination with antibiotics to treat a bacterial infection of the stomach known as H. pylori or Helicobacter pylori. The brand name of the drug is Voquezna, and we already talked about it. Works similarly to PPIs by blocking acid production. So are there risks of taking PPIs long term? Well, there have been associations of taking PPIs long term and certain medical conditions. The evidence is kind of weak, but things that have been studied include a bacterial infection of the colon known as Clostridium difficile or C. difficile infection, hip fracture, kidney disease, dementia, pneumonia, have all been weakly associated with PPIs in observational studies. So these are not strong studies. They can only show an association and not causality. So it may be that people who have these conditions are also more likely to have GERD rather than the PPIs actually causing these problems. They did show in a randomized trial that there may be a slightly higher risk of colon infections with PPIs long term. 1.4% risk with PPIs compared to 1% risk with placebo. And so because of these potential concerns of long-term PPI use, we don't know that it causes all of these problems, but there's an association, and so it could potentially be the cause. We usually recommend these medications be tapered down to the lowest effective dose and stopped if there's no reason to continue them long term. Most patients with GERD do not need surgery, but if GERD is severe and not controlled by lifestyle modification and medications, then surgery may be considered, especially if there is also objective evidence of GERD on endoscopy or other tests. So erosions, Barrett esophagus, hiatal hernia, abnormal results on reflux testing are all evidence that surgery for GERD could be considered if not treated well by more conservative measures. So there are several types of surgeries or procedures that can be used to treat GERD. The most common is laparoscopic fundoplication. Another one is known as magnetic sphincter augmentation. Gastric bypass can be used for obese patients. Hiatal hernia repair can be considered alone or along with some of these other procedures. And then a newer one is known as transoral incision fundoplication, which is another type of fundoplication that is performed via endoscopy rather than general surgery. So let's talk about these procedures in a little bit more detail. Laparoscopic fundoplication is the most commonly performed GERD surgery. Laparoscopic means rather than using a large incision, several small incisions are made as ports of entry for surgical equipment. And this surgery can be effective at reducing reflux, but a small number of patients will have reflux or will have complications or require further surgical intervention. In the image on the right, you can see the parts of the stomach labeled. And this top part, known as the fundus, is what is used during laparoscopic fundoplication, hence the name fundoplication, which stands for fundus. And in fundoplication surgery, this fundus of the stomach is pulled by the surgeon so it wraps around the lower esophagus, and this is then sewn in place. And so the upper part of the stomach is sewn around the lower part of the esophagus and to act kind of like a restrictive belt to prevent reflux. And here's another image of a laparoscopic fundoplication. This one is known as a Nissen fundoplication. A Nissen fundoplication is a fundoplication procedure where there's a 360-degree wrap of the esophagus by the fundus of the stomach. A toupee fundoplication is similar, but it is only a 270-degree wrap of the esophagus by the fundus. This procedure may be just as effective as Nissen with fewer side effects. Another procedure is known as magnetic sphincter augmentation, and I'm displaying a picture of a bracelet because to me it reminds me of a bracelet that fits tightly around your wrist, but you can loosen as well to get it off of your wrist. So what this is an elastic ring of magnetic beads placed around the lower part of the esophagus, and this prevents reflux at rest, but it's not so tight that we can't swallow properly. It's kind of like this string bracelet that holds onto our wrist, but we can loosen it just fine to pull it off of our wrist. It can be very effective for GERD symptoms. If patients are obese, gastric bypass may be the procedure of choice if they also have GERD. So this procedure is also known as the Roux-en-Y gastric bypass. You can see on the right kind of the anatomy that is changed during a gastric bypass procedure. You can see that the top part of the stomach is separated from the bottom part of the stomach, and then part of the small intestine known as the jejunum is then connected to this pouch, this small gastric pouch, and this can help prevent reflux. So because by creating this small stomach, it limits acid production. The smaller stomach also has less pressure within it, and this can reduce reflux. In addition, weight loss further reduces abdominal pressure and decreases reflux. I'll now talk a little bit about hiatal hernia repair. Remember that a hiatal hernia is where the stomach is pulled through the diaphragm muscle in the chest up into the chest cavity. And on the right, you can see pictures of a normal stomach and esophagus on the left. You can see what's called a sliding hiatal hernia in the middle, where the stomach is just pulled straight up through the diaphragm. And then there's one on the very right side called a paraesophageal hiatal hernia, where the stomach is pulled up through the diaphragm on the side of the esophagus. And we talked about this. A hiatal hernia is when the stomach has herniated or traveled through the opening in the diaphragm muscle into the chest cavity. Hiatal hernias may contribute to acid reflux or GERD symptoms. The repair is performed by pulling the stomach back through the opening, back down into the abdominal cavity. The diaphragm opening where that stomach was coming through is then made smaller and closed with sutures. Mesh may also be placed around the area for reinforcement. after that diaphragm opening is made smaller. This procedure can be performed in combination with a fundoplication to treat GERD. Okay, now we'll talk a little bit about Barrett esophagus. Barrett esophagus is a precancerous change to the inside lining of the esophagus. It appears on endoscopy as a salmon pink area on visual inspection of the esophagus. It can be confirmed by taking a tissue sample or biopsy of the salmon pink area and viewing for precancerous change under the microscope. A doctor called a pathologist is a doctor that looks at things under the microscope to make a pathologic diagnosis. And they're the ones that can confirm if Barrett esophagus is present. So this is a precursor condition to developing a type of cancer of the esophagus known as esophageal adenocarcinoma. If Barrett esophagus is seen on endoscopy and biopsy, an upper endoscopy must be performed at least every 3 to 5 years to make sure cancer isn't developing. Let's summarize what we've talked about in this talk. GERD is a condition where stomach acid refluxes into the esophagus where it doesn't belong and causes symptoms. Heartburn and regurgitation are typical GERD symptoms. Atypical symptoms are numerous and include upper stomach discomfort, chest pain, nausea, trouble swallowing, pain with swallowing, belching, throat clearing, sore throat, sensation of something stuck in the throat, chronic cough, wheezing, and tooth erosions. Lifestyle modifications for GERD include avoiding late-night eating, avoiding large meals, losing weight, and quitting smoking. Mild cases of GERD can be treated with lifestyle modification and over-the-counter medications such as H2 blockers and antacids. More significant cases of GERD are treated with lifestyle modification and PPI medication. If symptoms are not controlled with lifestyle modifications and over-the-counter medications or PPIs, or any alarm symptoms are present, patients should be referred to a specialist. The specialist may perform or order additional tests, such as upper endoscopy, esophageal manometry, or esophageal pH testing. Surgery may be considered if PPIs are not effective in controlling GERD. If Barrett esophagus is identified on upper endoscopy and with esophagus biopsy, this condition will need to be monitored over time to ensure esophageal cancer is not developing. Thank you.